We will start with our session hot topic colonoscopy, and I'm very honored to welcome Professor Rösch from Hamburg, who will take over the discussion. And I'm very honored also to welcome Professor Bretthauer and Dr. Kaspar Truninger from Switzerland, and they will discuss now colonoscopy in the daily clinical practice with regard to the new studies which have been recently published. Thomas, the floor is yours.
Hot topic colonoscopy. Stefan asked us to mainly center our focus around the screening colonoscopy study. And you know the background. In Germany, we started with screening colonoscopy in 2002. And here are these case control studies which show that it's enormously successful. So a massive reduction of colorectal cancer incidence and mortality, comparing those people attending colonoscopy as compared to some unclear rest. And of course, there's a lot of advertisement, and we are so happy that over 20 years we saved 1 billion euros. But then there is this guy who went from Germany to the exilum in Norway and combined German with Norwegian mentality, which can be very dangerous. So, Michael, what have you found out? Well, what's the truth about screening colonoscopy?
Yeah, I don't think this is going to be dry at all, Thomas. So I can get the control over the slides. So down to earth, that was the title that was given to me, and I'm not sure about that, but we will find out in the next 10 or 15 minutes, and then we're going to have a discussion with Thomas and Kaspar later. So I don't know if you are aware, but in colorectal cancer screening, we are kind of in a peculiar and outlier position as compared to many other, or all, I think, other cancer screening areas. For breast cancer screening, you have mammography. For prostate, you have PSA. For lung cancer, you have CT. All one test for one cancer. We are in the fortunate but also a little confusing position that we have many tests and many test options. Here are some from a recent guideline, but there's more than FIT every year, every other year, then colonoscopy, sigmoidoscopy. You have also CT, you have the capsule, you have DNA with Cologuard and other tests. A lot of options, which makes it fun to work in this area, but it makes it complicated to find out what works, what doesn't, what's best. So how do you do that? How do you find out if things work when you talk to a patient or when you write guidelines? Well, I think it's pretty straightforward, but we are still struggling to do it. So what I think we all need to do is, number one, to compare the benefits of a screening test. And important here is that we talk about the absolute benefits, and I will come back to that later in the talk, and that we see what risk of disease the particular patient or individual really it is has, for example, for the next 10 or 15 years. And there are quite good calculators online where people can put in their age and their gender and if they smoke or drink alcohol over family history, and then you will get a disease risk back for colorectal cancer. And here on this slide, you see that on the left-hand side, you have a scenario where people have a 2% risk of colorectal cancer for the next 15 years, and on the other side, you have a 4% risk. 4% risk, 15 years, that's high risk. 2% is still high, but lower. Many people have a lower risk than that if you go into the calculator. But of course, age, for example, is, as you know, a risk factor. As people get older, the risk is higher. And then you do what these people in the guideline did. You explain what the risk is without screening, that are the blue dots, and then you explain how small the risk can get if you do one of these screening examinations. For example, and I'm just going to show you one of these because there's a lot of information here. For example, if you look at this particular here, so this is a patient with a 2% risk of colorectal cancer for the next 15 years, derived by the calculator, which is online. If you do no screening, then the 20 is exactly the 2%. It's 20 out of 1,000. If you do FIT every year here, or FIT every 2 years, you reduce the incidence just a little bit to 19 or 17. If you do a colonoscopy, from 20 to 13, and so on. That's what you get. This guideline was pre-Nordic trial. This is based on modeling, only modeling. But this is a nice way to show it to your patients or to your colleagues. So after the benefit, you have to talk about the harms. And here again, in that guideline that referred to you, the harms, and you know all of what that is about 3 in 1,000. Again, you use the same absolute measures. Here it was per 1,000, here it is per 1,000. So it's 3 per 1,000 or smaller. So you have the benefits and the harms. There's one thing left that is called burden. So what does it mean to have a colonoscopy, for example? Is it painful? How long does it take? What does it cost? What about the bowel preparation? These are things that you also need to explain to people. It's harder to quantify things. Quantify the burden of a bowel prep. It's hard to do, but at least it needs to be explained so people understand, okay, what is this about? And a table like this is helpful. So before we go over to the trial data, let me just mention that luckily, and as we have seen, for example, just in the last hour, luckily we as a field improve all the time. And so the effect estimates, both for the benefits and the burden, they may change because we get better and do new stuff. For example, we know that ADR, adenoma detection rate, is related to cancer risk of our patients. And this is a recent study, just as an example from the US, showing that people, and we know that, people who find more polyps, their patients have a lower risk. And because we are getting better, of course, the screening gets better. Another thing is AI, CADe, CADx, we're talking about this all the time, which may have an improvement on what we do with patients, and therefore also effect estimates will change and need to be frequently updated for those benefits and for those harms. There's also harms related to CADe. Finding more polyps, maybe more perforations or more overdiagnosis. We have to take that into account. So down to earth, coming back to the title. As you know, colonoscopy is the primary screening test in the US. In Europe, not so much, but some countries do a lot. Some countries don't do it at all and do FIT screening. And the screening interval is different in different countries, so there's a lot to learn. The evidence before screening, and Thomas showed you a slide from a German study. Here are 2 US studies that indicated that colonoscopy may be very effective. 50, 70% reduction. National Polyp Study, which also is an observational study, 90% reduction in colorectal cancer mortality this is. But again, this is all observational evidence, and it's hard to make inference for clinical practice from observational studies. There's a lot of biases here. So therefore, usually when we, for example, start with a new drug therapy, we always want clinical trials, randomized trials. And this is the first one that we published a half a year or 9 months ago in the New England Journal, which is about colonoscopy versus no screening, a clinical trial, a randomized trial, just as we like to have to inform our policy. So the Nordic trial was a randomized trial in those 4 countries, Norway, Poland, Sweden, and the Netherlands, with almost 100,000 people. These screening trials need to be large because the disease risk is small, as I showed you, 2%, 4%, and you will see how much risk we had in the study. So you have to enroll a lot of patients to do a study with a good sample size. Important, everybody got randomized. The people who were randomized to no screening did not get anything. They were even not informed that they were in a trial. They just lived their lives. And there was no screening in the areas where we did the trial at the time. And the other folks got an invitation to a colonoscopy. There were no GPs involved. Letter straight to the people, come and get the colonoscopy. So as you can see, about 30,000 people were in the screening group and about 56,000 people in the no screening group. Most people in the trial came from Poland and Norway, just a few from Sweden, and from the Netherlands we had about 9,000 people, but these data are not included because somebody in the Netherlands thinks that they cannot share data with other people in Europe anymore after GDPR. It's a process that we hope we will win eventually. Screening participation, I will come back to that later, was 42%. So out of the people who got the letter, 42% showed up and had a colonoscopy, much higher in Norway as compared to Poland and Sweden, as you can see there. The screening performance was good. Bowel prep was good. Cecum intubation was good. Adenoma detection rate, I think, was good, 31%, as you can see, lower in Sweden than in the other 2 countries. It's a very simple explanation for that. I will come back to that. And few complications, which is important, harms. As I said, there was no screening for the people who were in the no screening group. It's probably difficult to believe for you who come from areas where screening is everywhere, but there was no screening in the areas when we did the trial. This is the main result, colorectal cancer incidence. As you can see, the red group is the screening group. They have a higher incidence to start with. That's entirely predicted because we find cancers at screening. And then the curve gets flatter, and at about 6 years, the curves cross, also that's predicted. And then the curve is lower in the screening group as compared to the control group, 18% lower. So that's the effect of colonoscopy screening, 18% reduction, 18. Of course, as I told you, not everybody showed up. That's the name of the game in clinical trials. So we also did so-called per protocol analysis where we only count the people who actually had a colonoscopy. That is high-risk business because then you get all the bias back from the observational studies, which we don't like. That's why this analysis, the primary analysis, in all clinical trials, not just in this one, every drug trial, every trial you read in the Lancet, in the New England Journal, in Gut where Thomas works, it's always intention to treat first because this is the result we believe in foremost. But we understand, it may get a result which is lower than the real result. So therefore, we also did this. So only the people who showed up, the reduction is 31%. This is the best you can get. It's probably a little biased, it's probably a little too high, but this is the best you can get, 31%. What about mortality? Well, very short story, no difference. As you can see, the curves are totally overlapping. I believe it's too early to see mortality results after 10 years, and the risk is very, very low. You can see it there. Almost nobody died of colorectal cancer in the trial out of the 100,000 people, thanks to the better oncological and surgical treatment we have now. Just one word about all-cause mortality. So death in general, no difference. I don't think that's very surprising, but it's a reminder to us that we should not say that colonoscopy saves your life. It doesn't prolong life. It doesn't. It can save you from getting colorectal cancer. That's pretty nice, but you probably won't live longer. You die of something else. There's been criticism. People will say, well, only 42% showed up. I think that's high. Some people said it's low. Well, the ADR was smaller than at Doug Rex's clinic in Indiana. Well, look at how obese the people are there, and you know that obese people have more adenoma, so entirely predictable. So here's what I think. Number one is adenoma detection is always a reflection of the prevalence. In Sweden, and I didn't show you the numbers, Sweden has a much lower prevalence and incidence of colorectal cancer than Norway and Poland. If you ask me why, nobody knows. If you find out, you'll probably get the Nobel Prize. But it's just a fact. And so there's less cancer in Sweden as compared to the other countries. Therefore, there's less adenomas. Therefore, people can't find the adenoma, so the ADR is lower. Logic. It's not a problem. It's just the way it is. Participation, well, if you want higher numbers, look at the per protocol or look to Norway. We had 61% participation, which is exactly the participation in screening in the United States. So our folks over there may look at those numbers. And then there's some stuff about sedation, which really is nonsense, I think. Okay, so I've jumped over this. So I think, ladies and gentlemen, colonoscopy screening still is a good thing. I think it should be offered if you want to offer it and you can pay for it and your country can afford it. But it's not a magic bullet. And then 80 or 90% that some people said, it's just, I don't think it was ever realistic. There's hardly any intervention in medicine which is 80 or 90% effective. In medicine, not in screening. I think 20 to 30%, for instance, is pretty good. And mortality we will see in the future. And then again, it's all about the benefits as compared to the harms and explaining it to people. And some people will say yes and others say no to screening colonoscopy. That's fine as far as I'm concerned.